One of the most common questions patients ask after a concussion is, why do my symptoms get worse when I use screens? And one of the most important things we can do as clinicians is avoid giving a one-size-fits-all answer, because screen intolerance is not always just screen intolerance. When a patient reports worsening symptoms with phone use, computer work, TV, or scrolling, that symptom response should not automatically be viewed as harm, failure, or reason to stop completely. It is clinical information. The key is knowing how to interpret the trigger, the symptom pattern, the intensity, and the recovery window. Early after concussion, especially in the first 24 to 48 hours, reducing or eliminating screen exposure can be helpful. There is evidence suggesting that heavier screen use in that very early window may worsen or prolong symptoms for some patients. But after that initial period, prolonged complete avoidance is usually not the best strategy. That is where the clinical reasoning becomes important. If a patient says, "Screens make me worse," we need to ask better questions. What type of screen activity? Is it reading emails? Is it different than watching a movie? Scrolling social media is different than typing a document. Playing a fast-moving video game is different than sending a text. Then ask, which symptoms worsen? Is it eye strain, frontal headache, blurred vision, difficulty focusing, or fatigue? May point us toward ocular involvement. Dizziness, nausea, disorientation, or motion sensitivity may suggest vestibular or visual motion sensitivity. Neck pain or suboccipital headache with sustained posture may suggest a cervical component. This is why "screens make me worse" is too vague. We need to identify the system being stressed. Now, the next question is dosage. How much did symptoms increase? How quickly did they come on? How long did it take to return to baseline? Did symptoms carry into the next day? A mild increase, maybe 1 to 2 out of 10, that resolves within an hour is very different from a significant flare that lasts several hours or causes next day symptom elevation. That recovery window helps us decide whether the exposure was appropriate, too intense, too long, or targeting the wrong system. Clinically, I do not want patients to become afraid or develop avoidant behavior. I want them to understand how to reintroduce screen use in a graded and intentional way. Because let's face it, screens are everyday reality for most of us in today's world. And to get back to normal, we likely will need to be able to return to screen work. For implementation, I usually think in a few steps. First, reduce screen use early, especially in the first 24 to 48 hours, when symptoms are more irritable. Second, gradually reintroduce screen exposure in small doses. That may mean 5 to 10 minutes of screen time followed by a break, then monitoring symptom response. Third, modify the task. Increase font size, reduce brightness, limit scrolling, use printed material when needed, use audio options, change posture, and break up visual and cognitive load. Fourth, match the intervention to the driver. If the issue is ocular motor control, we may need to assess pursuits, saccades, convergence accommodation, and visual endurance. If the issue is visual motion sensitivity, we may need graded exposure to motion and busy visual environments. If the issue is light sensitivity, we may need to consider autonomic regulation, sleep, exertional intolerance, and environmental modifications. If the issue is posture-related headache or neck pain, we need to assess the cervical spine. The mistake is treating all screen intolerances the same. For clinicians, the message is this: symptom provocation is not automatically bad. Poorly interpreted symptom provocation is the problem. When a patient says, "My symptoms got worse," we should not immediately say, "Then stop everything." Instead, we should ask, what was the trigger? What symptoms got worse? What did it feel like? How intense was the response? And how quickly did they recover? That is how symptom worsening becomes useful clinical data. If you found this helpful, download my free concussion symptom checklist to help patients monitor their symptoms and give clinicians clearer information for treatment planning. You'll find the link for the description below. And if you want a deeper clinical framework for evaluating symptom provocation, dosing treatment, and progressing patients with concussion more confidently, check out my Comprehensive Concussion Rehabilitation course through Concussion Spot Education. Put topics in the comments that you want covered. I want to hear from you, and go ahead, let me know what you want to hear next in the next video. All right? I'll see you in the next one.